Good morning and welcome to our monthly webcast. I am your moderator and this is session number 84. Today on June 21st, 2016, we mark our 7th anniversary of CCC livecases.org. It has been a great privilege for me to moderate these cases and I am honored to be a part of the wonderful team that makes this program possible. On the auspicious occasion of our 7th anniversary, it seems appropriate for me to reflect on some of the important contributions that our program has made. Although this webcast has been live for 7 years, the creation of this program took an additional at least 3 more years. During these formative years, Dr. Samin Sharma and I methodically constructed the format of this program. We were convinced that the internet was the best modality to broadcast and broadband development would make possible a very high quality transmission of these live cases. We carefully thought about the construct of these cases and we determined that each case must be genuinely technically challenging. These fundamental concepts led to the creation of complexcoronarycases.org. CCC livecases.org was a most simple but a highly effective description of what we wanted to do and what we have succeeded in bringing to the interventional cardiology world. Beyond the live demonstration of these cases, we wanted to enable an academic discussion about these cases as well as review the pertinent literature. We also determined, quite accurately I must add, that the duration of this program should be 60 minutes and that for logistic reasons we would telecast between 8 to 9 a.m. on every third Tuesday of the month. It's a testimony to how diligently Dr. Sharma and I planned the construct of this program that I am proud to state that after 7 years, we have made absolutely no change in the format of this program. Dr. Sharma continues to provide superb academic didactic about the case. Then he and Dr. Kinney perform, and today is the 84th of these outstanding and genuinely complex coronary angioplasty procedures. And I have moderated these sessions and fielded all your questions, hopefully with sincerity and with truth. Throughout this tenure, we have followed strictly an absolute no conflict of interest mandate. Our disclosures are highlighted in every case and there has never been a conflict of interest whatsoever. We have meticulously stayed away from endorsement of any drug or any device, and we have never abused the trust of the webcast for any commercial gain. The objective of our webcast has been and will always remain to be to provide unbiased, scientific and academic education. We have improved though, I must say, with every webcast. Mostly this has occurred with incorporation of technology so that the highest resolution of technology could be seamlessly brought to you. I must thank our technology team led by Ricardo Samariba that has enabled the superb transmission of each and every case. As a result of these efforts, we also now have an iPhone, an iPad applications, and today you can see us live on YouTube. There are several important educational initiatives that the program has championed. I want to highlight one in particular. This is our leadership in the area of appropriateness and utilization criteria for PCI or AUC. We recognize the supreme importance and relevance of this objective and we have championed this initiative in every webcast that we have done. I truly believe that the worldwide dissemination of AUC has been the biggest contribution of the webcast to interventional cardiology. We've also shared with you pioneering PCI techniques and helped the engineering and scientific advancement of several angioplasty devices. These include, but they are not limited to, OCT, the Impella device, angiosculpt, various CTO wires, bivalirudin and cangrelor. This is just to name a few. Our webcast remains truly dual purpose, helping educate interventional cardiologists and advance the development of better and safer angioplasty devices. Personally, for me it has been a joy to see Mount Sinai maintain its premier leadership role in the country. The cath lab maintains the best success rates and, most importantly, the lowest complication rates despite performing perhaps the highest number of complex coronary interventions. I am also delighted to observe the emergence of Dr. Kinney as one of the finest interventional cardiology operators in the world. Anu, congratulations. In Dr. Samin Sharma and in her hands, the most difficult patient can remain assured that he or she is in the most safe and capable hands in our country. Finally, I want to thank the nurses, the technicians and the fellows. Without their critical assistance, our webcast was never possible. In 2016, our webcast is watched by over 7,000 cardiologists in over 134 countries. I am humbled with this fantastic program, and I promise to continue upholding these very high traditions in every future case. With these words, I am delighted that we have accomplished 7 years of bringing educational interventional cardiology to you, and I am happy to take you to the Cardiac Cath lab where Dr. Kinney and Dr. Sharma are standing with another complex coronary intervention case. Samin, good morning. Was this appropriate summary?
Well, I can just wanted to congratulate with what a great summary you have put it for those our 7 years, and really reflects the main aim of CCC live cases, which we after initial inception started in July of 2009, and you have been a great supporter, and of course you moderated, but more importantly that always thinking, come up with the new ideas how to make it better and more access to the our audience globally.
Anu, congratulations to you. I have, as I stated, it's been an absolute joy. You stand there as solid as a rock, and no case how technically challenging is beyond your skills, and it's been an absolute pleasure watching you.
Thank you.
84 most incredibly complex cases you have performed live without any complications. We've had no death, no fatality, and it is a proud accomplishment, Anu.
Well, I would say that complication, we did have one major, but the word is the no death. We did have that acute closure of that left main,
right?
Requiring, so the major complication occurred. We did have some minor, some wire perforations and so, but in 84 complex cases, one major complication, and that patient still walked out of the hospital, was really remarkable. And I go beyond that, yes, techniques and the infrastructure support, but it goes beyond that. It's the third power, it's the God. Also, I always believe in that, and that's why our Tuesday is, but clearly that it has been a tremendous journey and will continue starting our 8th year, come up with some new ideas and some new plannings and maybe even new collaboration which are in works.
A lot of that is in works, as you said, but I think the biggest progress will yield from the YouTube, and hopefully this will bring the audience in seamlessly.
Good. So with before we start here, I wanted to just welcome Dr. Roxana Mehran, which has been our guest a few times here, and because today is one of the topic will exactly from heart of her field, and she'll give us an insight into it. But before we go on, let's quickly go through the case which Dr. Kinney is going to present. These are our normals. This is a 55-year-old patient who has class 3 angina last month, has 2 vessel disease after stress showing both anterior and inferior ischemia, RCA lesion, which will show you, and the LAD. Patient has LAD PCI, is on good medical therapy, and now here for the RCA PCI.
This is the left system. If you see, left main circ non-obstructive, LAD stent proximal which is patent, and here we are normal LV function, a old stent of the RCA that is totally occluded. You can see the distal vessel actually filling from the left side, and this is where we are. There is a proximal disease, but today the intervention will be a totally occluded distal RCA stent.
So, Anu, if this was 1998 or 2000, at least in Miami, we used to be doing 1/4 single pass with laser angioplasty after getting the wire through. But let us see what is happening in the lab today.
Yeah, no, that is true. I think at present, if somebody asks what is the indication of the laser atherectomy at present, I think one of them comes instant-restenosis. Although some, again, the major randomized trial still remain, although the original RBAC trial did compare laser, rotor ablation and PCI in B2C complex lesions, and laser was in between. Of course, the PTCA, the rotational atherectomy has lower complication, and PTC actually have a lower restenosis in those complex cases compared to laser or rotational atherectomy. But clearly this is kind of case unexpanded stent and total occlusion or the vein graft. Those are the 4 indications, because Roxana asked me to talk about laser atherectomy during ISCAI symposium, and I gave a brief view that where laser could be used at present. And we actually have seen, and even last week in our live symposium, there was one CTO and nothing else went, and George Dangus used the laser to recanalize that undilatable, although crossed with the wire, but no balloon crossed further on.
And some of our thoughts used to be that the laser in the protected environment of a previously placed stent had a unique benefit, but you are exactly right. One of those clear few indications where one could use it. Roxana, welcome to the webcast, and congratulations for doing a magnificent job during the recently concluded symposium.
Thank you very much. It's always an honor to be here and to work side by side with Dr. Sharma and Kinney. It's my pleasure to be here. Thank you.
And so what we'll do is, while we are trying to get across here, knowing once some technical challenge occurs, Dr. Kinney is continue to, you want to say anything about yoga now?
Nothing.
No. Yeah, that trying to go through this total occlusion, starting with the fielder wire and escalation, and we can finish our didactic discussion and in next 10 minutes.
Anu, a quick question. You anticipate this to be the bigger challenge is to cross with the wire, no?
Hopefully, since it's an instant restenosis, though it's total occlusion, looks like maybe no more than 10 millimeter of total occlusion. We'll just try the usual miracle wire and see how it goes. Once if we cross through, this is another important point, is that we do not have dual injection, just because if you see the total occlusion is in the mid portion of the stent, and you do see some flow in the distal part of the stent. Once we cross through the total occlusion, it should be okay, that we should be in the true lumen, and we do not have a dual injection. This is the only time I would say in this day and age when you have an instant restenosis total occlusion, you can probably get away without dual injection.
Excellent.
Good. So now which wire you want to do?
Give me miracle.
Okay, miracle 3 or 6?
6. So if we cross and we are in the lumen successfully, the goal should be that once we do that, we should consider rotational atherectomy.
So why would you not consider using like a Gaia or a pilot or a fielder or one of those?
The field, I mean, we tried fielder, right?
Yeah.
We are with the fielder. I just tried that. We are not able to cross the lesion. So now you go with the stiffer wire. So any of those wire that you mentioned could be tried.
Okay, so you
Either
could have tried those. It's
pilot,
just your
my choice was miracle, but you could go with the pilot, Gaia, or Miracle Bros.
okay.
Yeah, I mean after the fielder does not cross, my choice would have been the Gaia 2 or 3, and then if not, then you go to, but Dr. Kinney is very expert in this, the Miracle Bro. I mean, you need some stiffness, that's the key. So whichever way you want and whichever you the catheter wire, you have become good at it.
And Samin, that's the fine cross there?
Yeah.
This is the fine cross, yes.
Okay. And here we go. We've made
And this is the
progress
miracle
and,
6.
She's
And this is the
already
point clearly
across.
made.
the miracle performs the miracle.
Miracle.
Anu, really it has been a joy watching you operate and
extra
the
support
skills
wire.
you bring to the
Rota.
cases.
I think we got extra support rota.
Yeah.
Okay.
Yeah. Get extra support rota wire.
We have the floppy though.
Yeah, no, let's go to extra support. Now here it has gone distally. So question is which type of wire you use in these kind of cases. Since it across, I think 1.5 bar will be reasonable, and use the extra support rota wire, which will give you a little extra strength in this particular case, particularly going downstream and burr going through the lesion and so. So 95% cases are done with a rota floppy wire, and the indication for the rota extra support would be the ostial lesion, because where a guide has to be disengaged, and second would be any distal lesion which will require advancing the burr. So it's very common in an angulated circumflex, the lesion in the AV continuation, RPDA. So you need a support. So difference on the wire is actually the overall body of the wire is not different. Its only difference comes where the transition occurs distally, and the spring tip. The spring tip is shorter with a floppy wire, 2.3 versus 2.8 centimeter, and the body transition which occurs in about 8 centimeter segment versus in about 15 centimeter segment. So that's the rest of the body of wire is same, 0.009, made of stainless steel, and the coil, spring coil, is attached at the tip.
Samin, in the meantime, I've received congratulations for the 7th anniversary from several operators in India, as well as one from Brazil from Dr. Roberto Botelho. Roberto, welcome to the webcast, and it's been a joy getting the Brazilian interventional cardiologist involved.
I'm good beyond. Yeah.
So once you see that we crossed and we were able to get the fine cross across, you will see, you take a cine, you do see the distal vessel very well.
Okay, now connect the balloon and everything. Give me now full 10 minutes. Okay. So
Anu, you are happy with the wire in the
key
branch
is that
it
wire
is,
we
not
can
in
change,
the-
because we are not going to touch the spring type of the wire.
Okay.
It will be before the bifurcation. So key is we always try to make that just concentrate on the main thing, knowing that the wire will move after we open the distal segment or ablate the distal segment. So it's not an issue. So and we, yes, during the process we'll pull back the wire, select the balloon and so. So now with that note we got we got a little ahead of the curve. No, you need a high pressure, long. We go back to our slide presentation.
Cutting balloon again.
Okay.
I would the guy flex
Then
down.
engine flex. All right,
3 to
yes.
5.
And-
No. 3 to 5.
Okay. So this basically is our plan.
3 to 5 flex
Try to
stone.
show IVUS and OCT use in this particular case. So now this is appropriate. It comes into U category because class 2 maximum medical therapy, intermediate non-invasive testings. So 2 points I want to give, and as you know that our always plan is the latest data, and the first one is the risk score for coronary thrombosis and major bleeding post DES, and second is the recent update on outcomes of transradial intervention. And remember, we just presented 2 months ago the data from came from the DAPT score in JAMA, basically prediction of the clinical. So they came up with a DAPT score, which you can use for both thrombotic event and for the bleeding event. And points were as shown here, that what you get exactly that the patients with the old age and so forth, smoking, diabetes, all really low ejection fraction, you put it here, you get a score of -2 to 10, and that is the key. So therefore, and you see the distribution of majority of the cases. So clearly the lower the score, the lower is the chance, we call it a low score, which they divided to less than 2 or more than 2. And basically what happened, the low score less than 2 in terms of MI and stent thrombosis was slightly different, but once you go to the high score, there is a higher difference in terms of MI and stent thrombosis in the short versus long DAPT. So, basically means that if you giving a long DAPT in those cases, based on the DAPT score, you are having a lower stent thrombosis in the high DAPT score group. Now, compared to the bleeding is a little different story. So, low score, by giving a prolonged DAPT, you have a more bleeding, and when the high score was kind of no difference, moderate or severe bleeding. So, it still was not really understood exactly this score, although it has been subsequently validated in the diabetic patients group. Dean Kyriakis presented that in JACC. What it led to the guidelines, and the guidelines basically is very simple now. PCI, stable patient 6 months, acute coronary syndrome 1 year. So, before we go on further, only thing which I, Roxana Mehran is part of the writing committee, from my personal point of view, and I'll ask her this question now. We understood this 6 and 12-month differentiation, very simple, straightforward. Only question is, this document does not give us a guideline that who should get it for 2.5 years, 3 years, which have been done in the studies, because other studies have gone not 6 or 12 months. Question is, who gets more than 12 months? So, what do you say, Roxana?
Okay. So, first of all, thank you very much for, I think it's really, really important for our audience and everyone to understand the DAPT score. The DAPT score was developed from the DAPT trial, which was basically a randomized study of 12 months versus 30 months of dual antiplatelet therapy. So I think this is a very, very important distinction. So the score is only good for at the end of 12 months of being able to have taken and tolerated dual antiplatelet therapies for a duration of 12 months, then you have to make that decision. And as you know from the DAPT study, there was a great benefit for reducing stent thrombosis and major adverse cardiac events, but there was a hazard of bleeding. And so therefore, the guidelines actually tell you you need to make a consideration. You couldn't go a class 1 or a class 3 for continuation. You have a class 2B, and it's actually there on the right side of your panel. Beyond the 12 months at the time of evaluation of the patient, you need to use, and they gave the DAPT score as one of the scores that you can use. And I think it's really, really important that in the context of understanding the DAPT score, there was a lot of overlapping risks of bleeding and ischemia that they had to take into consideration. And as if you notice, chronic kidney disease, especially for this patient who's on hemodialysis, is something for us to consider. We know that that's a very, very important risk factor for bleeding. So it comes back to the clinician to make an important judgment on what should be next, what should be the next step. There is no clear-cut recommendation of what to do and who should get it. You need to kind of use these algorithms to guide you.
Perfect. So this actually leads to a second part, and that is a score from the Paris trial, Dr. Her own study, that come up with separate predictors for both coronary thrombosis and major bleeding, because we know the two could be associated, two could be dissociated. So this basically came up from the 5,000 patients, 840 were excluded, then we had 4,200 patients, and came up with the two terminology. One was the coronary thrombotic event, CTE, which they defined as stent related, which was 45, or non-stent related MI, which is 106. So turns out to be at long term, which is a 2-year data, that you have more event with a non-stent MI, almost double compared to the stent related event. And second was the bleeding, which they defined as BARC 3 or BARC 5, as you see. And what basically came up is very interesting. So if you go to a clinical characteristics, which you feel like that what will be for the major bleeding and the for basically thrombotic events, acute coronary syndrome, patients with a prior PCI, underweight, high creatinine, those will be respective predictors of the event. What was very clear that on a long term data, your short procedural event does not matter, whether thrombotic or major bleeding, as you can see, whether they probably are important for the short term, but for the long term they are not important. So they really come back with a very nice score in terms of prediction for the thrombosis on the left side, right side being. So basically what has been said is really true, that terms of the bleeding, whether BMI, anemia, triple therapy, and of course the smoker, and of course on the thrombotic side, that your high creatinine, diabetes, acute coronary syndrome, and patient's prior intervention. So, this actually led to the development of the integer score for the major bleeding as well as for the coronary thrombotic event, and they came up with a very nice calculation and clearly probability of where the patients fit in the thrombotic as well as the bleeding, and very nice correlation. So, basically this is a great slide. So, basically they divided the bleeding score from 0 to 3, 4 to 7 and 8 to 14 based on your score from that integral score, low bleeding, intermediate bleeding and high bleeding, and then make a thrombotic integer score from 0 to 2, 3 to 4 and 5 to 10 in terms of high, intermediate and low, and basically you can see that majority of the patients actually it has to be the other way around, but the low thrombotic risk, as you can see there, in the low bleeding risk you have a higher low thrombotic risk. Once you go to the high bleeding risk, your low thrombotic risk become very small, and it is the rest of it which really goes up. So, basically saying that patients who are going to bleed more, those are the patients are also at a risk of higher thrombosis. But this is therefore it becomes a big dilemma for the physician what to do.
I think this is it's a little bit more realistic. First of all, a couple of difference between the Paris versus the DAPT score. First of all, we evaluated the risk of the patient at the time of PCI. So that's a very, very important thing, and as they got discharged home with dual antiplatelet therapy. So a different score than the DAPT score. In this score, we have you get basically two scores, a score for your thrombotic risk and a score for your bleeding risk for your patient. And I think that's incredibly important because there's so much overlap. And then you're able to actually plot the risk, and I don't know if you have the next slide that shows a nice plot, the following, this particular plot I think is incredibly important, where you actually can plot the patient in the probability of bleeding and the probability of a thrombotic event over a 2-year period down the line. And I think what's great about this is that you can continue to evaluate the patient in that way. Again, the most important thing is that there's so much of an overlapping of the risk factors of bleeding and thrombotic risk, because the higher risk patients bleed and thrombose. I think that's the part that you need to take into consideration and evaluate these patients accordingly. And you can reclassify the patients depending on whether they're low risk for bleeding or a high risk for thrombotic event and vice versa. And I think that's a very, very important, yet another tool for our clinicians to use.
No, are you ready to change DAPT for 6 months now, routinely in our patients now, uncomplicated stable CAD patient?
I think that's what we are moving towards with the newer generation stent, which we have seen. If they are low risk, we should be thinking of going to 6 months.
Yeah.
And in fact, we are even thinking with the synergy that you can even consider if you are doing a single vessel mid RCA in a normal person with no other risk factor other than hyperlipidemia and hypertension, could we even be thinking about 3 months now?
No, and I think this is really, really important to think about this as a risk related to the stent, and this is what you're talking about, stent related risk, and they are becoming less and less and less as we're getting better and better with our DES technology. But the outside of the stent is an important risk, and I think you saw from Paris that the majority of the myocardial infarctions are coming outside of the stent. So you've got to make that choice. So of course you say single stent. So what's really important is if you want to send this patient to surgery, you're going to sleep well at night if you only had a single stent in the right coronary artery with a, let's say, a polymer free or even a Zion stent. At 3 months you don't have to worry about, oh, what should I do? Should I bridge? Remember the days when you were doing all of that. I don't think we need to do that, and I think that's a real relief now. The rest of it is about the risk of the patient and putting that into perspective.
You can bring it in while finishing the remaining. Yeah.
Sure.
So now you stay here. So therefore, actually, risk score from Paris, I think it comes out to be very simple. Let them come inside so that we continue. Yeah. Actually, there was a clearly what Dr. Mehran just said. Overall, the editorial really puts this one, that this is a general consensus to say you can have a risk modification based on the score, but it's ultimately you decide on the case-to-case basis. There is no clear-cut algorithm, and editorial of myself and Dr. Babar, that once you go beyond longer you are out, bleeding takes the major stage. So, I think what we need to remember, beyond after 1 year, 2 years, it is the bleeding, it is not the thrombosis, it is the bleeding, as long as you are taking care of the rest of the risk factor modification, and that is the key. So, therefore, basically 6 months, I think some of the cases even you can do less than, as Dr. Kini just pointed out, bleeding event, patient going for surgery, some of the stents, and of course, some of them clearly the group which is coming out is the prior MI and diabetes. So, those are the group you may need to continue longer, because I think although no prospective randomized, but sub studies have shown that way. The second, very quickly, the update on the outcome of transradial intervention, because we know the latest data again came that radial access reduced mortality in patient with ACS, and this is again 17 randomized trial, all showing that overall the curve is on to the left, that there are 27% reduction in mortality in acute coronary syndrome, and these are the individual endpoints: reduced death, reduced MACE because of the death, reduce excess site bleeding, reduce major bleeding. These are the odds ratio and the confidence interval. No difference in recurrent MI, no difference in stroke, although some studies in the past did show higher stroke, and of course, higher rate of crossover, which is about 6%. What came up with the new one is the detailed assessment of the wrist axis of the cath and PCI, the data presented of 190 patients in the Euro PCR, and they did a very detailed examination in 2 weeks with the echo Doppler, volumetry of the hand, and basically sensory test, ask the patients to fill up many of the parameters and the grip strength, and to the surprise, which we always have taken very lightly, binary score, that of these cases 75% of the patient had, those who have intervention had some kind of wrist dysfunction, and this is really shocking, and to happen majority of these 10% of the patients had a total radial occlusion. So, this occurred in the younger patients and the patients who have radial occlusion. So, what is the importance, and of course, 20 patients even went for hand rehabilitation. So, basically the moderator of the Euro PCR, I wasn't there, maybe Roxana or one of you were there, really said that it feels like that you have dropped a small hand grenade into the radial community. So, basically this goes to the various points which we have always come up in that yes, life saving, but we are having with the radial some good issues: advantage, decreased mortality, vascular complication, access, comfort to the patient, early ambulation, overall PCI cost, many of them no effect, MI, overall MACI, stent thrombosis, stroke or non-excess site bleeding, and many things have come up now: disadvantage, crossover, radial exposure, radiation exposure, increased femoral complication in this radial fanatics who have not used the femorals, increased radial artery occlusion, and latest being the hand dysfunction. So, I think this field will continue to evolve, and here
Samin, just staying on this slide, if you look on the right side with the disadvantage, radial artery occlusion 4 to 10% should really go into the vascular complications on the left side, no?
Yes.
But you are exactly right, it somewhat tempers the unbiased, unprecedented enthusiasm which it was having, and I think we need to be very, very careful and extremely vigilant about some of these events.
Good. Okay, now you want to just say what you are doing now, which bar?
Anu, before you tell us, 2 quick questions for you. One of them is there a role of any imaging modality here? And the second question which has come for you is, why not do just plain old balloon angioplasty?
Okay, 2 things. Yeah, imaging modality should be considered, especially when there is ISR, to understand what is the reason of ISR. You know, 2 reasons: is it just intimal hyperplasia under expanded stent? So, that will help us what should be the treatment for ISR. And the second question, that is, why can't you do balloon angioplasty alone? If you see here, when somebody is present with the total occlusion, there is so much of intimal hyperplasia, just balloon angioplasty and the treatment, which could be that you may just leave it with balloon angioplasty, which means restenosis is way in the, you know, about 30% or so. Or if you want to do another stent, you need to have a good luminal gain even before you put a second stent. For that, you have to do some kind of atherectomy just to get a good luminal gain. So, that is where we are. Either you do rotational atherectomy plus minus cutting balloon, and then you can evaluate how your lumen is, followed by another stent.
Excellent.
So, here we are, I think we are just going with a 1.5 burr. since we were able to cross a total occlusion with the fine cross, which means the lumen is not that tight, we can go with the one fiber. When I was a fellow, I was taught rotational atherectomy. The first few cases used to be instant restenosis,
Right,
because there is no
exactly
risk of perforation. So,
Anu, would 175 have been an overkill here?
yeah, we have, the thing is, you could still develop lot of slow flow.
Right.
With this, once you have total occlusion and when you are doing a oversized burr. Our usual teaching of a gradual, slow pecking forward motion continues, but still you could be a little bit more aggressive in getting your burr through the lesion.
Look, just in this case, like in so many others, you've taught the world how to perform safe
And,
rotational ablation.
Also very important is, when you are going through the ISR part of ablation, it will be smooth.
Right.
The most important step will be when you are just about to exit the stent, you have to be very slow.
Careful.
That's
What
the
is
time it may jump and cause dissection.
How many
perforation.
RPM are you there at?
We are about 156 to 158. Now this is where we are at the exit entry, so just you have to be very careful when you are coming out of the stent. Slow.
No EKG
Yeah.
changes, no chest pain.
She is having chest pain.
Yeah, she
You are
does.
just
Take a
asking the
picture.
question, and she's okay.
Okay.
Now you want to know,
Time
but it's
possibly
still
to
there.
take a
Let's do one more.
Okay. Yeah, just to coming back to the point of the what should be the appropriate size burr, and I can tell you that I gone through this, the overall teaching, you will never repent using a smaller burr.
Right.
Although you can repent many times using a bigger burr. So if required in rare cases, you can go to the second burr, and that is the key. Only accept even in the cases with the our instant restenosis, because many times your burr will not cross, so many things will happen, and the slow flow will develop. Let's come back to the guide and we take a picture that we are done. Right? Take a picture.
Okay, you will not see a
Okay,
good
let's
one.
come out there.
Get the run through.
And the key is that in these cases, do not hesitate to combine atherectomy with atherectomy. Right. So therefore, you have just taken ablated part of the intimal hyperplasia, or in this particular case, if it was new intimal hyperplasia with or new atherosclerosis. But the question here is, we don't know, because this is many years after the bare metal stent. So it could be any, but presented with a total occlusion, so very tough to say. But key remains the factor in this particular case is that that after you have done the ablation, and then you take a picture, and if you think like you need to go to a different bigger burr, or use a cutting the atherectomy, which we call.
I think we
Wonderful.
here should
Excellent
be.
lumen.
We'll just do a flextome.
Yeah. The
Right?
Yep.
Now
that's
you
fine.
want to do the imaging
Flextome
before or after?
No, I think that we should do the imaging now. Once you put this into the PDA. Well, the question is, you want a flextome or you want angioscope?
No, we opened the flextome.
Okay, flextome is fine. So now we are going to put a wire into the
maximal
PDA.
Lesion modification here.
Yes.
Sameen, I have been camped here in New York City over the last 2 days, enjoying your live symposium. 16 cases in a day without breaking a sweat. How is that possible?
And of them, 3 were tower, 1 was the pulmonic valve, and 1 alcohol septal ablation, and 11 of them being the coronary.
Truly, I believe a lot of that credit goes to teamwork. You were supported by a whole team of wonderful operators, excellent fellows, great nurses and technicians.
Of course, without that it's not possible, and this goes to even getting at everyone playing their role at level to get this.
Now what are you doing? OCT now or no? Later?
All right, let's do the OCT. Yeah. Okay.
see.
I think let's see the OCT. Are we
Sameen,
ready with the OCT?
Which would be the single best educational case out of the ones you did?
Well, I mean again, I can ask, but from email point of view and text point of view, before I answer, you tell me, you were there entire day or no?
I was there the entire day. I thought the TAVI case, you know, which was the
TAVI
most
was the most, absolutely the first case, everybody says very educational. Now, the really impressive, one is the educational, which one was the impressive case?
I would actually call the same one. There
No,
were,
one is done educational, that's done.
Right.
So, you need a second category.
There were, I think,
One case.
a couple of CTOs which were very nice. I found actually the alcohol septal ablation to be a remarkable case, a beautifully handled case in less than 3 minutes.
To me, by far, I really was completely, totally blown away with the Lima to the LAD rotational atherectomy.
Another great
There
case.
was so many teaching points there on how to handle the rotational atherectomy in such a complex case. I have to say, that case to me wins the prize.
Roxana,
Well, I can tell you.
absolutely right.
No.
But we have done that live here, so I
So many times. No, you are right. We have done
No,
so
but
many. So, but the just from the
So
audience,
many
I mean,
steps.
faculty point of view, and some of the audience people who have said of course, by far the tower case, lot of educational, but they really were impressed by the Lima to LAD.
right.
Yeah, it was really.
Anu, which was the most technically challenging from your point of view?
The LAD wrote off a 93-year-old guy.
Fantastic.
I don't know what the Lima to LAD people,
Yeah.
I can tell you that
Yeah,
was
yeah.
the most technically challenging.
Yeah, that was quite challenging
To
too.
our
to do a rota when there is in a patient, you saw the LAD as soon as we wired, we had so much wire bias
and in a
in a
young
calcified.
young
Young guy,
93-year-old.
with the occluded RCA.
Right. To our audience, you can download the CCVVC Symposium iPhone app. Just go to the Apple Store and download it, and you should be able to view
Are
all
we
the
able to
cases.
see now?
Yes, I think they are there.
All right, show the OCT there, right?
No, let me see thing.
Yeah.
Good, right? Okay, one of you go there, please. No.
Roxana, quick question for you.
Yeah.
The DAPT strategies, how would they be affected with BVS?
Well, I think we need data. There's
Ready?
very little data on discontinuation.
Yeah.
And as you know, those trials are all mandating at least 12 months of dual antiplatelet therapies. And I think that we need to be cautious, with a first generation device, and I think that's absolutely fine. And as they get, progressive, if we had done the same with we did do the same with original DES, first generation DES, and we got into trouble. So I think it's good to be cautious until we know what's going on, and as the next technologies, thinner struts, etc., come along, I'm sure we can modify the dual antiplatelet therapy regimen in those patients.
When are you expecting approval of the BVS technology?
Well, as you know, there was a 9-to-1 vote in
Right.
favor, and hopefully we'll hear very soon from the FDA. I'm obviously, just like any other user, waiting to listen to FDA
Better?
approval,
No good?
and hopefully there will be a good result.
And we plan to do a BVS case next month.
Right.
If it's approved. Hopefully it will be
Yeah.
approved.
Yeah.
For an indicated patient, I think it could be very effective.
One of in my introduction,
first, right?
when I was stating some of the things which we have been able to do, Samin, I have always been amazed at the quality of the cases you have selected, and they somehow magically appear and seamlessly fit into our educational repertoire.
Okay, let's do the flextome.
No, but first we want to see what.
No, it didn't happen.
They didn't get a good view. I think you have to do the flex
Same.
tome first.
It's too tight.
It's such a tight lesion there.
Yes.
Just to
Which
go back to our,
provides-
no, we tried twice OCT,
Right.
same, if it is too tight, many times it.
No, which also is explains the rationale when you wanted to use additional atherectomy device.
Yes, so I guess we have to do the atherectomy, except that we will
3.25.
not understand the plaque
The pathology,
morphology.
right.
Yeah, once we cut it, we will not understand.
Samin, going back to the AUC criteria, that should truly be the approach of every interventional cardiologist world over to view the cases and to prepare intellectually for that?
Yeah, I mean, absolutely. I mean, I think that's probably, I can tell you, the AUC criteria is more for us, for the United States, because you know that it's a 3.25.
Yeah, I know.
Okay, low pressure, yeah.
Okay.
Because what happened is that of
ISR.
that in this particular case, what the whole guidelines were developed out of United States, the most of the patients before getting for the stable CAD, PCI, they are on multiple drugs.
Right.
So they are clearly the PCI is a only occurs after the patient is symptomatic on the medical therapy. So what I would say, outside and knowing that I can speak for both India and here, being the 3 days every month spending there, that I am doing only 6 atmosphere. Is there is more important is the lesion significance. So we know that reports of cases being done which are non-significant getting a PCI, that number I would say in a United States because of close scrutiny is very little, while it is quite high outside.
Samin, I can tell you that problem is being seen in many countries in the world. I know it's happening in China, it's happening in various other Asian countries as well as in South America.
Yeah. So therefore, coming back to the point for the global perspective, do it now here.
You are outside now.
Yeah.
Okay, little bit.
Okay, and then we just do proximal segment. So therefore, the OCC more for United States, the lesion assessment for a physiological significance is more for out of USA globally.
I think you're
Go
going to
here.
have to put another stent anyway.
Yeah,
You have to put 2 stents anyway.
Yeah.
You need to pull back a little bit. Yeah.
What stent?
I'm more concerned about all the diffuse disease distally.
Yeah.
What's your plan there, guys?
Let's see. Now we will see now.
We'll be able to
Distally,
actually
if
see.
we need a different
Because I
balloon.
think your outflow is could be another reason
Have a
why.
2.5/20 balloon ready if we need.
Yeah, I think
Okay,
you
ready?
need to do some dilation down.
Right?
So
Yep.
Okay, Sine, right?
Yep. So far so good.
You want to put a 2O?
You see
No,
that
but no,
distal?
I would say directly we put a stent.
Yeah,
there.
in that
Yeah,
distal
but
area.
what size?
I
2.5.
agree.
No, we put 2
2.5.
stents here. First we do a 2.5 23 distally or 28,
yeah, I
and
agree.
proximally we put a 38.
Yeah.
No, did you want to do OCT now? No, right?
No, I think after the stent now. Now you do after the stent.
Sounds a plan, Samin. It's
Just to
also
make sure you have a good, I think you have too much. You see in that distal area, I don't think even OCT you'll get anything.
Huh?
No, Promus. This
Promus.
is a Promus case.
it's very noteworthy that 7 years, 84 transmissions, we've had virtually an unchanged crew, and 5 people I want to mention by name. Of course, I mentioned Ricardo, in addition Guy Puglisi, Michael Hellman, Tom and Chris Kadevas. Same team,
Yes.
they have mastered it, they have guided us, they have improved the transmission, and none of this was possible without their
At the end
endeavors.
we mention yoga. At the end we mention yoga.
Yeah, do. No, but and not
yet,
only
not yet. Quick,
yeah,
finish. 2
and
minutes
not
left.
only that,
2 minutes.
that they help because after the marathon symposium, as you said, 16 on Friday, they remind me I got a call from Sri Lanka that make sure you are relaying the case.
Right.
I said, whoop, we totally forgot about 11:30 p.m. for the Lanka Society
And the team is here.
of cardiology. So we did a case relay from 11:30 to 12:30. You go to people.
Just fantastic.
And then of course this is the crew.
Big
Same.
mistake. you
Well,
Should have gone with
also the
longer
credit
stent.
goes to
Now
your
38 will
nurses,
not cover.
technicians,
Okay.
fellows.
No, we need to dilate with the balloon anyway. It has not crossed. So you want to do it, take it out, and
Predilate.
it's not going. Yeah.
Yeah.
2.520 balloon we have, and then you use a different stent. Yeah. Yep. Yep. What we get? 2.5 32.
Yeah.
32.
Take a put a 30. 2.532.
Yeah. And proximally we can take a 3.5 38. Or you want 38 distally? No.
I think
No,
38 is
that's
too long.
32. So that was 24. You want
It's too
28?
late. Let's Dilate and see quickly.
Let's see
You're
when you
getting
open
the
it.
hit.
I think it's so hard to see, guys, because it's diffusely
See the last
diseased, as
picture?
you said.
Play the last picture. Yeah, let's see. Good. Okay.
Yeah, I think you need at least a 28.
28 or 32 distally, and then proximally,
see.
so that you can take care with the 2 stents
Balloon
only.
will help
Cannot.
you.
Go.
What I am saying, from here to here will not be 38.
Okay.
So you cannot put a 2.5.
Good.
Yeah,
the
that's
20.
what
Go up.
needs work there. This is a 20 millimeter balloon, Dr.
Yeah.
Sharma?
Yeah.
Down.
So there's a
There's a
pretty,
lesion there.
I was surprised that was more discreet there.
Yeah.
I
Very
said
discreet
it, the
lesion.
lesion there.
Go
That's
up
why
here.
you couldn't see
Okay.
anything by OCT
Yeah.
because of the lesion.
So then you want to OCT then now?
No, down.
I mean, since you did so much work. Let's take a picture first.
Okay, ready?
Now you're going to see better. Nice.
Something there very distally there.
Yeah.
No, no, no.
That's
That's because
just a
the wire
branch.
is in a small branch.
Yep.
Hopefully a little nitro and
Distal in the
Okay.
some branch.
Yeah, now got better.
Good. That's fine.
That's good. And there's a branch there.
Yep. Good. Okay. Let's
So you
play
want to
and
put,
decide the
but
stent.
then it will be 3 stents.
What
Yeah.
was
I
that
think this is
stent
the
you
3
just
stents
had, Dr.
anyways. I think
Sharma?
let's use a 3. One is small distally, then mid and proximally you need a 2 different sizes.
Yeah, because
This-
sizes are different.
yeah, we knew that this is the case of the 3 stent approach.
You want to do the OCT? If it was on the
Huh?
same side. OCT or no?
I would say that since we had done so much painstaking and we could not show earlier, I think we should do the OCT.
I mean what 2016
CT will show
what
you
is-
how underdilated that stent
Yulia?
is in the mid.
OCT.
what's the top
Okay.
stent in your cath lab today?
Stent?
Yeah.
We are
The DES what?
half and half.
Okay, which
Yeah,
one?
we are half and half with the Promus, and within the Promus about 10-15% synergy.
Excellent.
Yeah. Now question is why there is synergy? There is little premium on synergy because other stents are doing quite good also. But yes, patients when there is an issue about long dapt and so synergy, and also synergy very flexible. But all these particularly Zions Alpine also working very well.
How is this recent information on Transradial going to affect, you think?
Well, I mean, I think it definitely made a lot of people nervous.
Well, no, I think let's take a deep breath here. You know, there's no question that radial approach is having a very, very important impact on reducing bleeding complications in hundreds of thousands of patients that have been reported. If there is, and remember, this particular study is somewhat biased. It's not like it's a randomized study. It's a reported number of cases. It's kind of just like when you hear something like that, I think it's important to pay attention to it. But I don't think it should, like, you know, all of a sudden you don't throw away the baby with the bathwater, right? And so I think let's not, you know, forget about the fact that radial approach is a very important impact on how well you're doing.
We'll have
Now
to
you can
watch
see
how the area progresses.
Okay.
So I know that, Dr. Kinney, you're extremely patient with this technology. I tell you, I've already lost my patience. So tell
Believe me.
what is the how is it? What's the Zen you're taking to be able to do this 4 times before you get an image?
Okay, ready? It went before us.
No, leave
Okay.
it. Let's put a stent.
Done.
Good. Bye bye.
So you didn't answer me.
It's done.
Yeah,
Kinney.
I mean,
You,
yes,
you know,
of course.
it's amazing. No, but I think it's important because it's such an important technology, and that you have to be patient. I mean, when we see your studies with hundreds of patients with OCT, you have to understand the kind of diligence you have to actually do these studies.
No, no, it's very important that this particular imaging has to be done right, because many times we could put the patient at risk. You
Sure.
see that with so much of dye distally.
Right.
Yeah. And I think we got some, did we get some image?
Not really.
Not the stent. Okay.
Yeah, while we are doing it, if you go back to my slide
And the patient gets chest pain.
and go to that slide, because right, I was the OCT, nothing being shown.
Nothing.
Good. Okay. So read that. I wanted to just read it. It's a very nice with the editorial. Go to the slide, please.
It's right there.
Yeah, good.
Okay, move.
So
Let's
that
go.
the existence of the paradoxical increase in vascular complication with the TFA in radial centers have been described and should be considered a training program and by default radial operator. Now question is, what is the optimal case distribution between TRA and TFA? There is no clear answer. The European consensus paper on the TRA recommend performing at least 80 procedures via TRA annually, and more than 50% of the TRA procedures are in routine practice once the learning curve is completed. So the basically is that you don't need to be, the question I think is clear, that you are 100% radial fanatics, you get little trouble. You do a 100% femoral, you are trouble. So basically should be 60-70% radial is good. So you are basically making that statement that 20-30% femoral is appropriate, because that 6% crossover rate which probably occurs after a lot of struggle. To get the 6%, you probably struggle in 15%. So that is basically the question comes. So I think identify those complex cases. You don't need to be the radial hero in every case. It's a reasonable that you make a decision. So having 50, 60, 70% of the procedure done as a radial, I think it's a, you want to do a little touch up there?
No.
Yeah, distally.
Distally.
No,
touch up with
okay.
this.
I think it's just a spasm.
Yeah, but you need little 2 atmosphere there, breaking the spasm.
I'm telling you, that's, I think you take out the wire, it'll get better.
The wire is
Don't
out
go
of it.
behind. Yeah, now we stent.
Okay. So what size now you need?
3.538 open.
Open 3.538.
Samin, I think it's very important also today. I'd like to acknowledge a few other important contributors to our live cases, several guests we've been having, and some I would like to mention, of course. Foremost is Dr. Valentine Foster, who's been with us on several occasions, and Dr. Spencer King.
Yeah.
Three 5.38. Is that correct? That's what you want, Dr. Kinney?
Yeah.
Now we are the 3.538 going into the distal to mid RCA.
Samin, a specific question for you has come. Which is your preferred long stent?
I would say, I think at present, although we don't use much in terms of the resolute integrity, but I think these all stents have probably become basically level the playing field. So, but one thing for sure, from deliverability point of view, what we are really giving, I am giving some extra point to the synergy. With a thin strut, it really is doing the great job of distally. Yeah. Get one more.
Yeah, go up.
One more same size, no?
3.5.
But question is 32.
No.
Let's see, you measure
24. How high? Okay, good.
Fine.
Down. I need a high pressure balloon. 3.520 high pressure.
Or 30.
Or 30. Okay, 30.
Good. Let's put a second stent and then.
And our ISR is very important. You do atherectomy, atherectomy, place a stent, and then post dilate.
Yeah.
All these steps, right? Okay.
Good. Want to go up a little bit?
No. Let's see the length.
I think same size.
No, you don't want to come up to the ostium. You want to put a 24? The big disparity now.
I would
that
say at
seems
least
right.
32.
20. Huh?
3.532. The real challenge will start with a thick micron, 150 micron strut once we start getting the absorbed.
Right.
So, we
Yeah.
have to
We
retrain
have
ourselves
to retrain,
and
absolutely.
That's when you start the Zen, when you are not able to deliver it.
Well, today is the International Yoga Day, so, right, Dr. Kinney, you're leading a whole effort on that front too.
Roxana,
we
amongst
can
the
post-dilate
various,
off the
you've
line.
got such a international footprint.
it.
Which country are you
Finish it
most
quickly.
impressed with
Looks
their
like
status of
cannot be
PCI
late. I cannot be late.
Yep.
outside the US?
Oh,
In the developing world, I
well, you know, I have to tell you, I spent a,
Sendai.
you know, that I go to China every year,
Back.
and
and guide out.
I was just absolutely over the top, totally impressed with what I saw at the in Beijing.
at the
and
CIT.
Good, right?
Yeah, at the CIT and
Yes,
at their
ma'am.
institution, their
No,
new
no.
hospital, their
That.
new heart hospital.
Okay.
I tell you, I was absolutely beyond. I've never seen anything like that, you know. And
Yeah.
I think that the sheer volume of patients that they have and the good work that they're doing
Aye,
with
stop.
imaging,
Go down.
with
You
the
cannot get the
technology
light
that
out.
they have available, I
Deploy
think
the
it's
stent.
incredibly
That is
impressive.
not coming out.
I
Okay.
think
So-
they are also building a very
They can deploy
impressive
now?
research infrastructure.
Okay.
Absolutely,
Unnecessary
absolutely. I
pronouncement.
really was, you know, very, very impressed.
You know, the
So-
National Science Academy and the cardiology societies, I've been helping with
millimeter
a lot of their STEMI initiatives, and I share
Go in.
exactly the same sentiments.
And you know, Professor Runlin Gao and his team and what he's done
Okay,
for
down.
China, and how there's so much education, there's so much enthusiasm and zeal in the younger generation there that want to learn. And it's incredibly impressive, I have to say.
How is India doing?
I think very much the same, obviously on the technology front. And now that Dr. Sharma is there, I'm sure that the love will spread. And I hope to go there someday and work with Dr. Sharma, I hope.
Look, I think this is these are very important developments. You're talking of almost 2.5 billion people.
That's right.
And if there is advancement and progress of the technology there, it helps mankind in an enormous way. Everything is looking very good, just that
We need a little
it's
touch up
ostium
distal. Yeah.
and the distal, yeah.
All right. So, with that note, let me just come.
Post quickly. Finish. Non.
So it's just cosmetic work that's
Yeah.
left here,
Give me
but
the
this is just
post-dilation balloon.
beautiful,
Good.
beautiful work, Anu.
Thank
So,
you.
while we are finishing that, they can continue on one side, and let's finish our slide presentation, so that we are on time. Just few minutes. Basically, the thrombotic and bleeding risk score post DES is the coronary thrombotic and bleeding events at long term post DES can easily be predicted by simple clinical characteristics, but not by the procedural factors. Patients at high bleeding risk are also have higher thrombotic risk, and a decision about prolonging DAP needs to be individualized. Second, the recent meta-analysis have again demonstrated that transradial intervention is associated with lower mortality in ACS patients. This hand impairment post-radial intervention is of clinical concern, and its incidence and long-term impact need to be prospectively evaluated in a large series of patients, because this is the first series of 190 patients. So, quickly finish my 3 questions. That following statement is false integer risk score for major bleeding in the Paris study, age less than 50, anemia, triple therapy on discharge, CKD stage 3 or current smoking. And the second is following is the false integer score for coronary thrombotic event in the Paris study, the diabetes, ACS, current smoking, prior PCI and higher BMI. And the lastly, the recent study showed that transradial intervention was associated with hand dysfunction in percent of cases, 100%, 75%, 50%, 25% less than 25. All the question answers are always present on our website, and we appreciate and of course invite everybody to visit and look at the answers.
Very good questions.
Anu, teaching points of the case from you.
I think one important point would be the same could you have done a balloon angioplasty alone versus you have to do atherectomy? I think we did show that atherectomy did help in this particular case, get the initial lumen, and then same good stent expansion after we have done atherectomy plus atherectomy with stent, and then again post dilate. It is very important that you do all these steps, especially when you are taking care of instant-restenosis that has presented with the total occlusion. And the wire of choice down, I think we went over that. You try to use your initial wire, which could be usually a fielder. If fielder does not go through it, then you start going to the stiffer wires, which said how you escalate. If miracle had not gone through, then we would have changed to confiance at that time.
Excellent.
I also just want to say that we should not forget that this woman is only 55 years old. She's a 55-year-old woman with end-stage renal disease. These patients are at a very, very high risk. So for those of you who take care of these patients, it's great to get a great intervention, but the most important thing is what you do with them outside of the hospital with risk modification, and knowing that they're going to have progressive disease, and caring for them is incredibly important.
Anu, angiographically absolutely
Gorgeous.
perfect, excellent distal flow, well expanded
Beautiful.
stents.
All right.
You are satisfied?
Yeah, looks good. I know there is a distal disease in the PDA at this time. I think you should leave it alone,
Right.
and just treat medically for the distal disease at this time.
She's
One-
much better off now than she was an hour ago. That's for sure.
Wonderful. Sameen, any concluding words on session 84 from you or from Anu?
But thanks for our supporters and to make this symposium, this monthly webcast possible. Supporters as well as our audience who continues to keep us excited and keep up the numbers up in terms of the total hit to the our page views as well as the countries.
Excellent. This has been another excellent session, a lot of good teaching points. We conclude here and see you for session 85.
I want to mention
Anu?
that today is June. June 21st, which we are for the first time actually celebrating here in Mount Sinai Heart, the International Yoga Day. I always expected you to ask a question. You asked us several questions, but one thing you never asked is that how in this busy interventional cardiologist life we are still able to do this many cases, take care of this patient and work long hours, is that we got to also take care of ourselves. So I always believed that health is a very important part of our life, and I personally take care of myself with routine exercise as well as yoga, and I also believe that before we can tell our patients that they have to do lifestyle modification as a part of a primary prevention or secondary prevention, before you preach you need to practice, so you can tell them exactly what you need to do. That is for the patient. Second, you need to include what I would say the mind and body health amongst the people you work with. The thing is same, it is a very stressful life everybody has, especially in the New York City, that how can you stay healthy, number one, and happy. So if you are happy at work, I think you have a better mood, and then people want to come back to work, and there is never this kind of stress in your co-workers saying that, oh, I don't want to go back to that lab and have another stressful day, instead be happy. And how could you get that mood going with them is that we have included lot of this kind of exercise activities in within the cath lab. We actually had a run in the springtime, and today we have the International Yoga Day. You won't believe so much of excitement that has been going on in the staff and lot of people around who have been part of practicing, making this particular event happen. So we once this is done, we'll be going there at 9:30 to start that event.
So maybe you could do a webcast of the
Yoga.
yoga session next time and just teach us how you do that.
Cath lab will come to the stand still, the grounding, the halt with this yoga program. So much excitement here about that also.
Anu,
It has been super.
I congratulate you on this, and of course I will be joining you also, and I have absolutely no doubt in the purity and the simplicity of your message. It clearly shows in your team, and I am glad you mentioned it.
Beautiful.
Thank
All
you.
right.
Bye-bye.
Thank you.
See you back session 85 on July the 19th, and it's been a pleasure bringing you this program for the last 7 years.